Population health refers to the health outcomes within a group of people rather than considering the health of one person at a time. Population health, tonight, on call with the Prairie Doc. Good evening, and welcome to another episode of On Call with the Prairie Doc, medical information based on science, built on trust. I'm Dr. Andrew Ellsworth, your Prairie Doc host tonight. Thank you for joining us. Tonight's topic is population health. Population health focuses on the health outcomes of the population as a whole rather than individuals. This is closely related to public health, which is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private, communities, and individuals. Joining us to address this topic is Dr. Tom Dean from Wessington Springs and Dr. Tad Jacobs from Flandreau, South Dakota.
Great to be here.
Thank you for joining me. Tom, if you don't mind going first, tell us a little bit about yourself and your background.
Okay, well, I grew up on a farm west of Wessington Springs, went to high school there, but after that, I wandered around the world for a while. I went to college in Minnesota, and I went to medical school in New York. I spent a year in England, and then when I finished medical school, I had decided that I really was interested in family medicine, which was a brand new idea at that point, and ended up doing a residency at the University of Washington in Seattle, where I met my wife. And she was, by the way, the very first nurse I met as a quivering, scared to death young intern. And then we spent 3 years in southeastern Kentucky, where Kathy went to midwifery school, and I practiced in an organization there. And then we moved back to Wessington Springs in 1978 and have been there ever since.
Excellent. Well, thank you for joining us tonight.
Well, it's a great pleasure.
And Tad, Dr. Chad Jacobs, if you'd mind sharing us about yourself.
Yeah, no, happy to. So it's funny how women just kind of shape our future, isn't it? It's just something that happened with us, too. So Kathy and I met in a hospital in Michigan. I was a respiratory therapist at the time. She was an LPN in peds. We met setting up a croup tent, Tom. Do you remember croup tents?
I sure do.
So that's where it all sort of began. Ultimately, I ended up in medical school in Des Moines, and then I had a National Health Service Corps obligation. So Flandreau qualified as a site. They had a doc there who was looking to retire, and I joined that doc and bought the practice in 1982. So practiced in Flandreau, cradle to grave, kind of a practice. Loved every minute of it, and did that for 28 years. And after that period of time, I'd done a lot of work with Avera. We eventually sold our practice to McKinnon at the time. And then Avera kept growing. We became involved with that. And so I had an administrative role with Avera the last 10 years of my practice. So 38 years or so in all, and it's been a great ride.
So as Chief Medical Officer with Avera Medical Group, obviously you were able to have a hand in public health and population health.
Indeed.
And Dr. Dean, could you explain to us your role with the National Rural Health Association and your hand in population health, public health?
Shortly after I moved or started practice, I got involved with a group called the National Rural Health Association. And it just seemed to me at that point that the needs or the concerns for rural communities and rural patients were just not being adequately addressed. And this organization really was speaking to that. And so I got more and more involved with that organization, eventually became president after a number of years. And so was involved with, they were involved with health policy development and lobbying and those kind of things. And then eventually, through that organization, I got connected with a group called the Medicare Payment Advisory Commission, which was probably the most involved health policy activity I was involved in. This was MedPAC is a branch of Congress that advises Congress on Medicare policy. And it was, so I did that, going a lot of trips to D.C., back and forth. I was still in practice. It wasn't a full-time job, but we talked about a lot of the problems and the changes that can come in Medicare and the things that Medicare does well and the places where there are problems. It was very interesting and a very challenging experience.
So we've got 3 family docs that care deeply about our communities.
Our community, right?
And that have also been involved in more than just taking care of our practices, but being involved in public health and population health. So thank you for joining me. Before we start our conversation, we invite you, our audience, to submit your questions about public health. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into our drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but please provide contact information when you submit your question. So, going back to some of these the questions about population health and public health, looking back in your careers, what is an example of a successful public health initiative you have seen in your career, Tom?
One of the things that I remember vividly was when I was a resident and early in practice. There's a disease called H-flu meningitis, which is a devastating disease. It's a brain infection that comes from very common bacteria. And at that time, the only way it could be diagnosed was with a spinal tap, and any kid that got a fever, any baby with a high fever, ended up with a spinal tap because it was the only way that it could be diagnosed, and it was terrible if you missed the diagnosis, because kids died from this, and even those that survived, some had long-term disabilities, and so it was really a horrible thing to deal with. And about the time I entered practice, the vaccine for H-flu, for Haemophilus influenza, became available, and that disease disappeared. In fact, I would venture to say that most physicians in training will never see a case. And yet we coped with it all the time. And we treated this life-threatening disease in our little hospital in Wessington Springs because there was no other place to do it. And we had an infant die in Wessington Springs from that. So it was a tough challenge, and it was totally eliminated when the vaccine became available. It was just a marvelous development.
We're both old enough that we remember polio pretty well, right?
Right.
You think about that and how it impacted so many millions of people, and that was long ago, but kind of ushered in that era, understanding we can do things to control disease and impact people's lives, which was just an amazing advancement at the time.
Yeah. One of the things that I think that we may suffer from today, suffer probably isn't the right word, that vaccines have been too successful. And some of these things that you and I had to deal with years ago are not around, but the infectious agents are still there. And if we let up on these interventions, especially childhood vaccines, and it's a real concern because the data we see, those numbers are going down. H-flu meningitis will come back, polio will come back, measles will come back.
And we see some measles outbreaks, we see some mumps outbreaks.
Yeah, and so I think those of us that have been around for a while really worry about that prospect, that we get, there's lots of reasons people come up with why I don't want this shot or that shot or whatever. Some of them are legitimate. They're not shots cause some problem. But compared to the devastating impact of these infections, it's really nothing.
And we're really quite educated, you know, in these last 3 years or so about how, well, in the case of COVID, right, how viruses can mutate and change and still continue to infect us over time. So diligence is the key.
Yeah. With so many of these public health initiatives, there involves individuals giving up something for freedom, a stab, some of their time, some effort, but for the greater good. You know, what are they giving up and what are they gaining?
Well, that's where the challenge comes, that we balance the potential gains against whatever cost, in a very broad sense, there may be. But a lot of times it's giving up a little bit of freedom or a little bit of potential risk from some of these interventions. Most of those risks are very small, but they are real.
Yeah, I think, and you know, I'm concerned about education, right? That we're not educating folks enough or in the right way to understand, you know, the degree to which research and studies have led to these things finally being available to them. And so the danger is really ignoring that and then thinking that you're going to be okay, when in fact you may not be okay. It may affect a lot of people around you.
Yeah, I think going back to the vaccines and childhood vaccines, and with some young parents deciding not to vaccinate, I think they're weighing in their head, well, they could get the vaccine, but do they really need it? I never see these diseases. I've never heard of anyone having these things. And then what if it causes something for them? And so then they choose not to do it. And how do we overcome that?
Yeah.
It's a big challenge, and I think that as medical care has become more and more complicated, more and more fragmented, oftentimes patients don't really have a good relationship with a doctor or another provider or some other expert that can help understand the pros and cons of all of this. And then we have probably not done a good job. Sometimes we have put in regulations that require things that people may not fully understand. And when you tell somebody they have to do something, they may say, get their arch their neck and say, yeah, you can't tell me to do that. I've got a funny recollection about that. A very long time ago, when I was about 10 years old, South Dakota did not require driver's licenses. And then they passed a law that said that you have to have a license if you're going to drive a car. And my dad blew up. We had to peel him off the ceiling because who has the right to tell me I can't drive my own car? But it's the same issue, that once, I think we would all agree that there's plenty of good justification for driver's licenses. But
Sure.
But it wasn't clear to him, and he wasn't going to have anybody pushing him around, But so it's not a new issue. So a lot of it has to do with how well we can do in explaining this to the people involved, and first of all, we have to know. We have to know what the pros and cons really are,
Right.
and sometimes we do, and sometimes we don't.
It all boils back down to education, right? How well are we educating people? And I think in the case of most recently COVID, right? That's what we all are understand probably the best. I don't know that we did the best job of educating folks about the safety of the vaccine that came out. Setting the whole politics thing aside, right? I mean, a lot of people felt like it was rushed into it, something that was suddenly created. It wasn't safe, it wasn't tested. The reality, it had been over a decade that they'd been working on this mRNA technology, right? Amazing. And the fact that it came to be available as fast as it did was really one of the remarkable advancements of medicine and science of our day anyway. So I think we, that being healthcare, need to really step back a little bit and say, how can we do a better job of educating our patients so they don't have that fear?
Yeah, because we'd always traditionally had to grow the vaccine components,
Right.
incubate them, and that took time, or attenuate them, make them weaker, as opposed to here we could just program that genetic material in there.
Amazing.
Much quicker.
Yeah.
So yeah, and to appreciate that.
And I think it all moved so fast, I think, especially with COVID, that we all of a sudden had a huge threat, and we had some tools, but they were new, and I know that there was a lot of criticism of public health authorities. Well, you should wear masks. No, they don't do any good. In fact, we didn't know in the beginning whether they did any good. We know now they really do provide a protective effect. But I think people took that differing opinions to mean we didn't know what we were doing, and in some cases they were right. I mean, now I think it's been around, and the studies have been done, and we know. But it was hard.
But it comes down to that thing where people have to give up something.
Yeah.
You know, and when even masks, when you're wearing a mask, you're mostly protecting everyone else.
Right.
Unless it's a really, really good mask, and then you're protecting yourself. But you know, if I'm in surgery and I have a mask on, I don't have a mask on to protect myself from this patient who's unconscious there. I'm wearing a mask to protect them from any germs spewing out of my mouth.
Right. Exactly.
I think some people see people with masks and think, oh, they're scared. They're loving their neighbor.
Yeah.
They're caring about their neighbor. Maybe they've got a cold or a cough, and if a person does, hopefully they're wearing a mask when they're out.
I think that's an important point, and it's especially true with something like COVID, where people can be totally asymptomatic and still be infected and spreading the disease.
Yeah.
That's one of the really difficult things, and why the public health authorities have pushed, for instance, especially masking, and people objected because they say, well, I feel fine, I don't need that. Mm-hmm. In fact, they could be infected and they could be spreading the virus to their neighbor who might be very susceptible.
And you know, I think we as healthcare providers can sometimes do a better job of saying, you know, we really just don't know yet.
Yeah.
You know, or something to that effect, to say, because there's a lot of gray in medicine, right? We just don't know.
Yeah.
So.
When disaster strikes a community, it's important people know what to do. Having an emergency plan is the best way for community members to understand what their role is in a crisis. Prairie Doc reporter Sam Schauer spoke with a Brookings County official on how their plan operates in times of need.
Robert Hill is on the board of the Brookings County Pandemic Planning Coordinating Committee. Around 2005, they enacted the Be Ready Brookings emergency plan to respond to disasters. Bird flu was a concern at the time.
And about what our records show, 2005, 2006, they started to make planning in case bird flu migrated to humans.
The plan soon added flu vaccination points of dispensing, or pods. Hill said the pods would be located at hospitals, stores, and the Dakota Bank Center. He also said the lessons learned from those vaccination pods were critical when the COVID-19 pandemic began.
And we would use those instances as exercises to make sure our pandemic plan worked. It wasn't the pandemic of 2020. It wasn't the COVID pandemic, but it was giving us practice. Giving all those flu shots up until the time really helped.
Hill says the committee likes to run a full-scale exercise of the emergency plan every 3 years to simulate an emergency. That way, everyone knows the plan, and those exercises range from pipeline issues to power line predicaments.
And we simulated that a vehicle hit an electrical pole, knocked the electrical line on top of the combine. Now you got a farmer inside the combine. He can't get out because he's got a live electrical line sitting on his combine. So we scrambled the fire department out and went through a full-scale exercise on how to get that farmer out.
The last simulation they ran was in 2021, and another emergency they discussed were strong winds and how they could affect the community. A year later, the derecho hit Brookings County. Hill credits the committee and the plan for the swift recovery to get everything working again.
A lot of power poles came down, and like I said, we was out of power for, I want to say, 26 hours here in the city of Brookings. And once again, that day, our emergency planning in the city of Brookings really showed, because we had our emergency operations center working within an hour.
Hill concludes by saying he and the committee can plan all they want, but it's the people and emergency responders who are the ones who help save the community in times of crisis.
You can't have a good emergency management operations, or you can do all the planning you want, but it's the people that make them plans work.
Well, we sure appreciate our emergency responders, big time. You know, have either of you been involved in emergency management plans?
You know, you can't live in a small town without. I mean, you wear a lot of hats, right? So you can't, but you can't get away from that. But we have very close relationships with the emergency responders in our community, and you know, one of the things that we do in terms of preparing for what might occur is simulation of scenarios, accidents, right? And usually that occurs at least on an annual basis, but sometimes they're pretty elaborate, right? So you know, a bus overturns and you've got 20 kids that are hurt, and you know, some seriously, some not, some hysterical, some not. But we play that role down to at the scene with some pretty good cosmetics going on out there in the field, and then in transport back to the hospital, triaging those patients. We even had a helicopter fly in one time, right? So you know, those types of things. You know, the more that you can do them, the more you're actually prepared for when something really happens.
Yeah. In that video, there was one example. There was mass vaccination in a pandemic, and we did have a question from an email, and we kind of got into this some, but this person says the politicizing of COVID-19 and the conflicting or misrepresented information caused the population to not trust the medical community. What can doctors and nurses do to reinstate trust so that the populace can trust?
That's a very important question without an easy answer. But I think that the bottom line is we need to do, and Ted already alluded to this, we need to do a better job of explaining both what the risk is and what is involved with any of these interventions, whether it's masks or vaccines or isolation or whatever, and how did we get to that conclusion? Because most people, if you give them a logical, sensible explanation, that will be enough. But too often, you know, we get rushed and we just assume that, well, we've got these degrees and so you just trust us. Well, years ago that was true, but it's not true anymore. And it's probably okay that it's not true. I think people need to challenge authority to some degree, but also they need to recognize when the authority or the individual that has in some authoritative position really has some good science behind their conclusions and what they're recommending.
It comes down to trust, and it comes down to establishing that relationship. I've had, thankfully, majority of my families will vaccinate, but some may go at a slower rate, or some choose not to. But I haven't told them I won't see them anymore. Sometimes some doctors will do that.
Yeah,
and then you're forming this barrier to trust and communication. And so I will still see them and care for them and be there for them. And prior to the pandemic, I slowly made progress with some families where, I might tell them about Hib and what used to be the case. And maybe they'd be, okay, well, we can do that one vaccine. And that would help to establish that trust and establish that conversation. But I tell you, it took a huge hit. Some of those families where we were making progress, they were done after COVID.
You know, I was just thinking as I was listening to the two of you, if I was sitting on the exam table and you were explaining that to me, you know, I mean, I would feel comfortable and I would trust you, right? And so, I mean, those relationships, I mean, you can't underestimate that. But what I would say is that, you know, healthcare is becoming more and more fractionated, right? And you don't know who you're seeing sometime. But if you're a patient and you're uncertain and you don't feel like you're getting the answers from your primary care provider or whomever, you need to let them know that. And then if that still doesn't help, then you need to look for another primary care provider.
And along those lines, this person says, how do we handle misinformation about vaccines? Where would you direct people, you know, besides their primary care doctor?
Right. Tom?
Well, you know, the probably the most well-known one is the CDC. And
granted, there's some people that are not going to trust them either.
Well, and they've made mistakes. I mean, so there is a reason. I mean, that would be where I would go first of all if I wanted objective scientific information. But I think that there's no easy way. Probably as I try to keep track of the news, I'm a real news junkie, but I can't trust any single source. I read about 3 or 4 different newspapers, and it's easy online now. And of course, it's so much more difficult now because there are so many sources of information, and some of them are spewing out pure garbage, and others are really making an effort to give good information, and it sometimes is difficult to sort out which ones really. So it's a very important question. There's not an easy answer, but it's important to try to find, especially an individual who you trust and who you believe really does have a good perspective on this.
You know, it's ingrained in us from our medical school days, right? I mean, we are data-driven, evidence-based medicine. We used to talk about quite a bit, but understanding that we don't push something forward in medicine unless we really have the background data to support it. And so, for patients, they need to understand, or at least ask the question, you know, so you feel that way. What is your source? What do you utilize?
How do you counteract, or you know, when someone has an N of 1? I know someone who did this and this happened. I know someone who did this and this happened. How do you?
That is a powerful influence on many of our patients. You know, I learned that when I came back to a small community. I'd been in academic institutions where data was the answer to every question, and yet I would go and say we need some to one of our community organizations or county commissioners or whoever that we needed to make some changes, and I would spew out all this scientific data, these controlled studies. It meant zero. Yeah. I mean, it isn't that these people weren't smart. They're smart enough, but that they just didn't have the advantage of the background to appreciate the significance of what a controlled trial really is. And so, but if their cousin had a bad experience somewhere, that was something that really meant something to them. And I understand that.
Where you've got a group of people that are randomly determined that these people are going to get the treatment and these people are not going to get the treatment. And these people don't know if they're getting the treatment, and they don't know if they're getting the treatment, and the people giving them the treatment don't know if they're getting the treatment or they don't know. Double blind,
yeah.
And then we see what happens, and we find that this many people were benefited and these many people weren't, and that was different than in the control setting, or it wasn't different in the control setting.
So you really can tell, because somebody will say, well, years ago, everybody got a cold, got a shot of penicillin, and they all got better. So that penicillin must have really done something. Well, in fact, we know now it didn't do anything. It was just the natural history of the disease. But you can't make that determination unless you have a control group, and it's.
stepping back in public health and population health, what are other efforts that communities do to engage and to decrease the risk and spread of disease? You know, I'm thinking back to garbage collection, clean water, you know, along these lines. That throughout society and civilization, we've learned that we have to do this collectively to help make our population healthier. Pasteurization of milk that we'll talk about later.
Sure.
Yeah, I think, and actually, if you look at the statistics and the history, it was clean water that probably saved more lives than anything we as doctors do. So those things, but people don't. I mean, we just forget about it. We just take it for granted now. And in fact, we shouldn't be, because there's some of those interventions are tremendously important and continue to be.
Yeah.
And we hear stories every once in a while where some water source we hear about it these days with lead pipes, that some communities still are getting their drinking water through lead pipes, and it's causing a problem. And yet it's a subtle thing, and until somebody really looked at it, they didn't appreciate that these kids were not developing and not learning at the rate they should, and by golly, it was probably from those lead pipes. And
so in many ways, it really is going back to basics, just like that. So nutrition is one of the areas, right? I mean, I think there's a lot of stuff out there that really talks about what is appropriate nutrition, and what are the bad things that we do, and I think that involves not just doctors, but people who are nutritionists and people who are in the business, the food business, for example. So, you know, I think those things collectively, looking at those simple things, you know, help us to overcome some of those issues. Right?
Yeah. Now I'm thinking of school lunch programs, and you know how important that is for the health of a community, to get the kids healthy, so that way they are not hungry and they can learn and be at school and
having breakfast for kids in the morning because the parents are working. I mean, that's in most of our communities, I think, these days.
I also think of smoking and secondhand smoke exposure, and how, you know, not that long ago, it was hard to go to a restaurant or bar without smoke.
Or get on an airplane.
Right.
I got stuck in the back seat with smokers all around me, and I thought I was going to die.
I know. It wasn't that long ago.
It wasn't that long ago.
And
from our perspective.
And now we take it for granted again. But you know, and there's so many people that did smoke that some of them are glad that happened, because that helped them quit too.
Yeah.
So there's many things we can do for population health, public health, that you know, none of us have our MPH, Masters in Public Health, but thankfully some people do, and many physicians do too, and others that help study these things and find best ways to help take care of everyone. Which goes along with, this person from Facebook said, when people are studying to make changes to healthcare, do they look at just populated areas, or do they look at smaller communities as well?
Well, I think that there certainly are some things where we're looking at the outcomes in small communities is really important, because we've discovered there are some real differences.
Yeah.
And so, in answer to the question, I think more and more researchers understand that you need to have different locales, different environments included, so that you can try to determine if the environment, or probably more specifically the access to services that people have, does that impact their health, and we know that it does. And you know, you spoke of emergency medicine. It's really a problem these days, because small communities are having more and more challenge keeping ambulance services running.
For sure.
And
nursing homes.
Yeah, and so if you have a bad accident or a heart attack, any number of things, the early treatment, we know, makes a difference and is important. And it's going to be, it continues to be a real challenge to get that that care to the people that need it in a timely manner.
And I think we have been working on that some, and really comes down to some of those social determinants of health, of factors that affect a person's ability to be healthy and get health care. And can you explain that some, and how we're looking at that now more?
Yeah, so we're talking a lot about things we think that we can change, but there's a lot of stuff that we can't change, right? And so, there was one study that actually looked and said, you as doctors and healthcare providers can only impact about 20% of a person's, life. So social determinants of health, things like your race, your language, what language do you speak, your education level, for example, transportation. Do you have transportation? And in some cases, even your zip code, which zip code you live in. So if you look at those, your race, we know, good example in South Dakota, Native American population has significantly less results or outcomes in terms of population health than the remainder of the population. Language, we still have some language barriers in the state, and we try to overcome that. But is the person who's really needing the care understanding what needs to take place? Transportation, for example, a lot of people may not have a car, may not be able to have transportation. They're using public transportation if they're in a larger town, but does that public transportation take them where they need to go? Can they get to work? Can they get to a clinic? Can they get to a hospital or emergency room? Can they get to a grocery store? Or are they using Quick Trip 2 blocks down the line for their groceries? Those types of things. And interesting study in Sioux Falls. It was in the Argus years ago. They took by zip code in the metro area of Sioux Falls and looked at number of deaths, number of people with diabetes, and certain diagnoses. This is all blind stuff. They didn't know the people. They just knew that they were in that zip code. And there was a dramatic difference, for example, between the south side of Sioux Falls and just that northern side of Sioux Falls. So where you live has an awful lot to do with that. We need to overcome those barriers.
Yeah. It's a real, as far as from rural communities, some of the technology has really benefited that. Just recently, there was a story about a fellow lives out of Gan Valley, which is just west of Wessington Springs, which is really out in the middle of nowhere. I don't think they would mind him. He was gored by a buffalo and seriously injured. But it happened that the ambulance from Kimball that picked him up had real-time video contact with the emergency service in Sioux Falls. And so the minute that fellow was able to get to the ambulance, his care was being monitored and advised by the emergency medicine specialist in Sioux Falls. And the ambulance brought him to our hospital in Wessington Springs, and then they flew him to Sioux Falls, and he eventually survived. But if it was nip and tuck.
Nip and tuck. That's great stuff, though.
It's amazing what we can do with some of those e-services now, if we use them. Within 2 days of birth, all newborns receive a standard health screening. A new screening was added to the list recently, thanks to a local family. Prairie Doc reporter Sam Schauer shares the journey of how their son's disease changed South Dakota's newborn screen.
Meg and Chris Haberman are the mother and father of Isaac. At 2 years old, Isaac was struggling with communication, so the Habermans took Isaac to be evaluated. It turned out Isaac also needed physical therapy, and the Habermans were ready for the challenge.
It was about 6 months into the physical therapy journey that the physical therapist kind of said, hey, he's only 2, but it's hard to tell with a 2-year-old if they're actually engaging in physical therapy or not, but we feel like he's regressing a little bit and not making the progress that we think he should be at his age.
Another 6 months went by of testing to find out Isaac had a muscular disease. In January of 2017, that disease was diagnosed as Pompe disease, which affects 1 out of 40,000 children a year. Luckily, there is a treatment for it.
It's every 14 days. We spend about 5 to 6 hours in the hospital, and he gets an infusion of the enzyme his body doesn't make. He's had 100 78 infusions at this point.
I mean, he did meet the benchmarks. It was just always kind of on the late side, but it was still kind of in the normal time frame. But now we see videos of him just struggling to walk upstairs without help. Something was going on. It just took us a while to realize that.
After infusions, Isaac runs and plays like he doesn't have a rare disease. But since it is rare, there isn't much recent data on the disease. The Habermans soon found out South Dakota did not screen for Pompe disease, although it was recommended nationwide in 2015.
It was around his 100th infusion. We had a celebration, and we just said we need to do something. Like, children born in South Dakota deserve screening for that. Time is muscle. If you can diagnose this at birth, like, we can prevent so much muscle damage with the treatment we have available today.
The Habermans started their campaign in 2020 by reaching out to many organizations, advocates in other states, and the legislators in South Dakota.
I reached out to our legislators. I figured that's a good place to start, and I said, how does something get added to South Dakota's newborn screening? And they said, we don't know. Let's find out.
Find out.
And found out the State Board of Health is the one who adds it.
We got the information we needed as to how it's done, and then we were able to just work with the Department of Health, and they reconvened a committee for newborn screening that hadn't been in place for several years, and we were able to share our story at that meeting.
And on September 1st, 2022, Pompe disease was added to newborn screenings in South Dakota.
I think we were told maybe in July that it was being added, and we knew it was coming. It took a while. I mean, everything takes a while. How do you make sure that every single hospital is equipped to do this and communicated and all the things necessary for this? And so we knew it was coming, but yeah, it was a big celebration when September 1st came.
For our family.
Yeah, in that last graphic, it states that South Dakota tests for 50 diseases in the newborn screen, and that's really remarkable, that family and what they were able to do to add that disease to it too. What is the newborn screen?
Yeah, so Tom and I were just talking about this earlier, and so when we were in practice, we think there were like 5 in that list of now 50, so that's pretty impressive. But I think the newborn screen for any child is extremely important, right? And so there's screenings that takes place just after birth, right? And obviously physical exam takes place, but then blood is drawn, cord blood is drawn to screen for a number of different diseases.
Yeah.
Right?
And even just a little heel stick, and
exactly right.
And honestly, that was the impetus for this show. I'd had a string of some young moms or parents that didn't want their newborn, to have the newborn screen, which it's actually the law to have it done because it's in the best interest of all parties, and especially the child, because if we can catch these things early, help them early, it can avoid brain damage and other problems. But it comes down to education, and they just didn't know what it was. Sometimes they just, I thought you were just going to poke my baby for the fun of it or something, and so just a little heel prick, and then they can save so many lives in the end this way. Right. And so it really is a remarkable thing. And we kind of already talked about what can we do to rebuild the trust in medicine. But
and at the time of exam, of a newborn, I mean, there may be no signs that you would know that there was a problem going on. So these tests would give you at least the background that, hey, you need to be looking at this, right? So
and at least for some of these, and probably most of these diseases, you have no way to diagnose them anyway. And by the time they show up, by the time that baby or young child develops some symptoms, it may be too late to treat them, because some of them are things that need to be, like thyroid is the most well-known one. It's easy to replace early on, but if they've already been damaged by the loss or the absence of that, it may not be repairable.
So hopefully if some of our viewers are going to have a baby or a grandchild or something, they say yes to the newborn screen.
Indeed, yeah.
And say yes to some vaccinations.
And I would have that discussion ahead of time with your obstetrician or your primary care doc and make sure that that's not a decision you're making at the point of the delivery.
Right.
I think that's
Right.
critical.
Right.
Yeah, that's really important.
There's been some changes in reimbursement and how we provide care for a population. Tad, can you explain that some?
Yeah, I mean, typically, we were a fee for service, and to a certain extent, we still are. So if you do a procedure or you see a patient, you spend the amount of time, you bill it, you get paid for that service, right? Well, as time has gone on, and they start looking at population health data, they say, well, geez, how can there be this discrepancy between providers in terms of caring for basic things like high blood pressure?
And I guess this is more of a 1-minute answer.
Oh, diabetes. Okay, diabetes. No, right. Okay. Right. So at any rate, the main focus is get it taken care of.
We need to change the incentive. I think the incentive needs to be on making sure we get the right care, not just that we get more care.
Right.
And in the fee-for-service system, the incentive was to provide more care.
Right. So reimbursement now looks at that. So what are your outcomes? And if you're doing a great job of taking care of diabetes and hypertension, you're going to make a little bit more, or you're going to be reimbursed a little bit more because of those outcomes. Yeah. And that's it in a nutshell.
Excellent.
Yeah.
Thank you.
Yeah.
The winner of our prize tonight is Gloriana. Thank you for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 21 seasons. Join us as we continue to provide health information based on science, built on trust. Follow us on Facebook, Instagram, and YouTube to access the entire Prairie Doc library today.
My father-in-law is a farmer. He grew up on the family farm in southwest Minnesota, where his dad grew up too. Blessed by fertile soil, the farm has provided for the family for several generations. It is invaluable for my children to experience the farm, see the crops grow, help with animals, and learn about the cycles of life on the farm. The farm no longer has cows, but it did at one time. My father-in-law used to milk cows. He remembers they had a pasteurizer. His mother would pour in raw milk, the cream rose to the top, and the milk would have chunks of fat and protein in it from curdling. He remembers thinking how lucky the townsfolk were, having cartons of smooth milk without the chunks. The process of pasteurizing milk was invented by Louis Pasteur over 150 years ago. One of the fathers of bacteriology, germ theory, and microbiology, he helped develop the sterilization procedures to kill off bacteria. He disproved a common belief at the time in spontaneous generation, proving that living beings do not spontaneously arise out of nothing. He invented the process of treating milk to stop bacterial contamination, now known as pasteurization, named in his honor. Rich in nutrients, milk is an excellent medium for growing bacteria. In pasteurization, milk is heated to destroy pathogens like bacteria and spoilage organisms like yeast and molds. This helps to extend the shelf life of milk. Very little nutrients are lost in the process, and often additional good nutrients are added, like vitamin D and vitamin A. Improperly handled raw milk is the leading cause of hospitalization for any food-borne disease source. Pasteurization can help prevent numerous diseases and kills the harmful bacteria Salmonella, Listeria, Yersinia, Campylobacter, Staphylococcus aureus, and Escherichia coli, among others. As more and more people are further removed from farm life, some people do not know where or how their food is made. Some take for granted the work and steps in getting the food to the grocery store. It is the pasteurization of milk that allows it to be safely consumed by anyone far from the farm. Without it, we could be at risk of getting sick from bad milk. Without it, we might not all be able to enjoy the nutritional benefits of milk, helpful for our bones and overall health. A big thank you to our guests, Dr. Tom Dean and Dr. Tad Jacobs, for volunteering their time to help us learn more about population health. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us live every Wednesday morning at 9:30 on KBRK Brookings, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science built on trust. Until next time, stay healthy out there, people.
Underreported and underdiagnosed, sleep apnea is a common condition that prevents your body from getting enough oxygen. Sleep interrupted sleep apnea. Next time, On Call with the Prairie Doc.
Hello, my name is Dave Heinck, and I've been a board member at Healing Words Foundation for the last 9 years. Well, my background goes all the way back to DeSmet, South Dakota, where Rick Holm and I were childhood friends. We were at USD together, and we've managed to stay close friends for our entire lives. And I spent the bulk of my career with Weyerhaeuser Company in the Pacific Northwest, and I led their production forestry research group. I also spent time on the faculties of Auburn, Virginia Tech, Purdue, and affiliate faculty positions at the University of Washington, University of Idaho. And in retirement, I've spent most of my time in the nonprofit world in board service. When Rick and Joni were putting the foundation together several years ago, Rick would call and ask a question or two, and I usually had the answer, or at least where he could go. And so eventually, he and Joni invited me to be a member of the Healing Words Foundation board, and that's how it happened. The foundation and the Prairie Doc media production is really committed to truthful, timely, tested medical information. And there's a lot of information out there now that's either half truth or no truth. And of course, being a scientist by profession, we're always seekers of truth, understanding full well that the truth can change with additional research. Every dollar that's pledged or given to Healing Words Foundation unleashes an army of volunteers. The foundation and the Prairie Doc Media puts out really good stuff, very useful things. So there's a high return on the investment to invest in the Prairie Doc. For more information or to donate, head to www.prairiedoc.org or send your donations to Post Office Box 752, Brookings, South Dakota 57006. Thank you for support.
Major funding for On Call with the Prairie Doc has been provided by
Out here, the day starts early and ends late. You don't love this land because it's easy. You love it because it's home. At Avera, we're built for rural healthcare. We're bringing quality, innovation, and advanced technology to your vibrant communities. Care when and where you need it. That's how Avera moves health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health, Dakota Dermatology, Vance Thompson Vision, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yenton District Medical Society, Orthopedic Institute, Aberdeen Asthma and Allergy, South Dakota American College of Physicians, Cool Beans Coffee, Lake Poncet Sailing Academy, and Swiftel Communications.